For anybody that's joining this webinar, please give us just a couple of minutes. I can see the numbers are going up with people that are logging in. It will just take a minute or so for us to start with questions and answers. And we just want to give everybody the opportunity to be able to log in time. We have lots of people from all over the world logging in, and for those of you whilst you're logging in, I just want to reassure you that we are recording the session. So if you have a Wi-Fi line that during this question answer time goes, you can of course log back in, but we will also on either both of our websites or through social media make sure that you have some access through the recording. So I can see the numbers are slowly going up, so give us another minute or so whilst the participants are just logging in. Right, I think it's time to start this Q&A webinar. It's an amazing pleasure to introduce Professor George Toit, who's a pediatric allergist, works at the Evelina Hospital, has also a busy private clinic and specializes, of course, in allergy, who's a primary researcher and part of the LEAP, so that's learning early about peanut allergy. George, it's absolutely amazing to have you here, and thank you for joining for this live and interactive Q&A.
Thank you very much, Rosan. Thank you to everyone who's joining us.
I wanted just to also, for those of you who are joining us, just give you a little bit of, just how this is going to work. I will be chairing this session. I will be leading the questions, but of course, I'm a pediatric dietitian as well. So what will happen is if there are questions that are coming through that are more dietetic-y, I will ask, George will sometimes just bounce back to me. On that note, I want to just say that this webinar does not replace a individualized session with a pediatric allergist. So that's, just want you to take that message home. So therefore also when questions come in, just want to ask you to anonymize the question. So please do not put your child's name in there. And also please take note. So if the questions are very specific, what I as a moderator will do is I will make them more general, because it's really impossible for George to answer very individualized questions on your child's treatment. So I hope you can understand that. Then in front of you, you should have two buttons. One is a chat button. Please do not send in your questions on the chat button. I'm not going to monitor the chat button, but I'm certainly going to monitor the Q&A button. And as questions come in, we'll of course endeavor to try to incorporate them. Right, so George, as you know, we've had quite a lot of questions sent in. So I'm going to try to have it in a sequence that somehow makes sense. So the first question I've got for you is, what type of allergy is peanut allergy? And does it always present as anaphylaxis?
So hi again, everyone. So peanut allergy is a well-recognized, probably the most studied allergy. So of all the food allergies, we probably know the most about peanut allergy, and that comes through all the emotion, necessarily so, that surrounds this allergy. So we know that it's a common allergy, particularly in industrialized countries, and increasingly in the developing world, bizarrely, that the rate of this allergy is going up. We know that it generally presents in the first year of life, otherwise the first few years of life. It's very rare that you will find an adult that de novo develops peanut allergy. Of course, that can happen. And there's a variant of peanut allergy that comes about through being pollen allergic, where peanut just tickles in your mouth. So that variant, called the oral allergy syndrome, can come on in older patients, and we can chat about that later. But the classic peanut allergy, as everyone knows it, comes on early in life. It's usually not a dramatic shock and horror presentation the first time, usually just of hives, some redness that come on some 10 to 20 minutes after exposure. Bizarrely, usually after your first known oral exposure, or after your first, second, or third is the typical history. And that raises the question, which I'm sure you'll get to, as to what causes it. If it's the first time my child eats this, they have a reaction, how did they become allergic?
No, I think that's an excellent answer to it, and we'll absolutely come to what causes it. So I suppose the next question I've got is it on the increase, or are we just getting more aware of peanut allergy?
So it has been increasing, yes, over the last few decades. In fact, it's been doubling over the last decades, and now sits again in industrialized countries at around 2%, perhaps a little bit below, depending on how you measure this. And I think this is a real phenomenon. It's not just that allergies are now better recognized, better studied, and better characterized. Because peanut allergy is a very simple allergy to study. If you're peanut allergic, if you eat some peanut, even a small amount will cause symptoms. The symptoms are classic. They're easy to recognize. The child or perhaps the adult who finds out they're allergic will absolutely hate peanut. They won't eat it sequentially. So it's fairly simple just on history to pick up that you have a problem with peanut. And again, with tolerance, if you can eat a handful of peanuts and enjoy that and have no symptoms, you are obviously tolerant. So the point is it's easily diagnosed. So I believe that increasing prevalence over the last 2 decades is a real phenomenon.
And George, I'm going to move into the diagnosis because we had lots of questions around the diagnosis. I think the first question is, how is it diagnosed?
So most parents whose child is peanut allergic, who I see in clinic and for yourself as well, will tell you that their child's peanut allergic. Everyone is well aware of this concept of allergy now. People are trying to introduce nuts early on in a safe format, not as whole nuts, as butters, pastes, or flours. The child will have some exposure. Perhaps the first time they'll hate it, they'll push away, they'll have an aversion, they'll lock their jaw. Perhaps you'll see a rash that may or may not appear like allergy to you if you're new to the allergy world. If it's slightly more significant and there's some highs and some swelling, perhaps a vomit, and very occasionally more severe symptoms in infancy, such as recurrent vomiting, coughing, altered voice, breathing fast, or an appearance that is grey, pale, limp, and floppy, then it's pretty obvious to most parents that this is probably peanut allergy, and they would then present to their healthcare provider, depending on where they are in the world, saying that they suspect this. And that's the sort of typical presentation.
And would you therefore, do you then go ahead to say, do you test it? Would you say, if you've got those type of symptoms, it's always better to then go and test it? And how would you test for the peanut allergy?
Correct. A diagnosis of peanut allergy is a serious matter. It alters your approach to food in your family and for that child for life. Every meal that is eaten after that diagnosis needs to be screened, or at least somebody needs to think, does this contain peanuts? So that's not a light matter. It's difficult enough feeding kids anyway, and now there's this extra layer of concern around it. So you do need that diagnosis to be checked on. And so generally we would do a skin prick test or a blood test just to confirm, particularly if that peanut was eaten in a complex meal. So the child is still young, you're not certain of tolerance to other foods, and peanut may have been eaten with some egg or some milk or some wheat or in a complex format. It's a bit simpler if it was eaten just as peanut butter, because you would know that the allergen then was just peanut. So yes, you'd want to have this diagnosis checked on. And of course, following a confirmed diagnosis, you would then need to receive a bespoke allergy plan. Does this contain self-administered adrenaline? Will you be trained in that? Will you be trained, obviously dietitians are experts at this, as to how to avoid peanut. So there's a lot that goes around the simple diagnosis of peanut.
Yeah. So we did have a question sent in, and I think that really fits in nicely around the testing, and is during the COVID-19 crisis, there's a lot of assumptions because there's no testing, no services available. And so one of the questions was like, this is a child that had some mild symptoms and testing has not been done because of obvious reasons. And they were told to say, okay, now you just assume you have a peanut allergy. So the question was, is it worth having the test, which I think you've answered, but also, are these tests accurate? Which I think is a good question to answer, is if you've got a positive test, does it actually really indicate you've got an allergy, yes or no?
Correct. So that question raises various points. The one is decreased access to medical care during the COVID pandemic, and that varies throughout the world. Indeed, even outside of COVID, people have very little access to allergy specialized care. But yes, it would be ideal if you can be assessed. And most centers in the world are slowly starting to open up to remote visits, where you can go through a history, and remote testing, and increasingly on-site testing, particularly for young infants, where you can still intervene and influence their allergies. if you can get to testing, there's three forms of testing. The one is the skin prick test. Then you get specific IgE blood tests. So IgE is the immunoglobulin E, the allergy antibody that you can measure circulating in the blood. And then the gold standard, of course, is an oral food challenge, where in a safe and supervised experience setting, you would give small increments of peanut to see if you can tolerate this, or if the child or adult has a reaction. So most commonly, we try and stay away from oral food challenges if the history is suggestive, and we'd go for skin testing. And as with all medical tests in life, tests are very helpful if they're absolutely negative. So the negative predictive value, if you have a skin prick test done accurately, the negative predictive value, in other words, the chance that if you eat peanut that you won't react, is exceptionally high. It's around 98%, 99%. So there's very little error in a negative test. You then get degrees of positiveness. And a very high positive test, as with all medical tests, carries a high degree of accurate prediction, a positive predictive value. And of course, between that, you get a slightly murky gray area where you're not entirely sure. And as clinicians, as you yourself know, Rosan, you then put your history together with risk factors, with that gray zone, and you try and come to a management decision.
It is like putting a puzzle together, and we often also, as dietitians, we bounce children back to you because, you know, it might have been that a test was actually just borderline, but then by the time that we get them, when we start introducing the solids, they then start reacting, and then it kind of comes back to you. So I totally agree. Whilst you were talking, actually, a question has come through, and I think it's a good time to ask, and that is whether there are specific proteins that you can test for that actually predicts reactivity higher, you know, rather than just, you know, just skin prick or specific IgEs.
So peanut is such a healthy food because it's jam-packed full of protein, has a very high amount of protein. Within those proteins, there are many variants. Some are stubborn proteins, not easily digested, that make for perfect allergens. Some are very labile, heat labile and digestion labile. And so they all behave differently biologically. Now, our tests have advanced somewhat. We can check your immune response to different proteins within peanut. And they all carry different degrees of positiveness. We talk of the seed storage proteins. So these are very stubborn proteins that conserve the genetic material of peanut and are usually associated with reactions. So they help predict, excuse me, a binary answer of yes, no to allergy, and to a lesser degree help predict severity. Severity is quite hard to predict just from the testing. So that's a new advance, but you can usually in young children get away without any of those fancy tests. Just a clinical history, a simple skin prick test. In the absence of that, a simple IgE to peanut. In the right hands, will get you a very accurate diagnosis.
And I think that's a really important message to have, that in the right hands, you can actually simply looking at the history and having the right test and knowing how to interpret them. I think that's also really important. George, what I think a lot of questions that have come through is regarding, you know, the adrenaline autoinjector, and whilst we can't today answer those questions on the individual questions that have come through, but I want to ask, just as a general guideline, how would you treat? So if my child has got a peanut allergy, how would you normally treat a reaction? And I know there's a huge range of reactions, but so just give us an overview, because I know you can't do specifics.
All right. So peanut-induced reactions can vary. They can vary each time you're exposed to peanut. It's very hard to predict severity. The one known risk factor is age. With increasing age, the more severe reactions are associated with increasing age, and also asthma. Most of the very horrible, thankfully rare outcomes from peanut occur in children with unstable asthmatic conditions. So the asthma we can control, that is very important. So as a medication, that's something you would chase down, environmental control, get on top of the asthma. As far as acute allergic reactions, the vast majority are mild to moderate and not life-threatening. Remember, most peanut allergics in the world never come near any medical care. They carry no medicines, they have no medical care, and thankfully fatalities are exceptionally rare. But fatalities do occur, and they're avoidable through proper dietetic management, learning about foods. And when a peanut does slip through and you have a reaction, they are generally treatable. So what I teach patients in their bespoke plan is for symptoms on the outside of the body. So a swollen lip, perhaps a vomit, perhaps some hives, slightly red eyes, and nothing more dramatic. And antihistamine, or even no antihistamine, will probably get you by. These symptoms will, in the vast majority of cases, just settle on their own. However, you can have internal symptoms. So once again, the cough, the altered voice, the extreme distress, severe abdominal pain, sometimes menstrual pain in older females. You can have collapse, but it's normally not dramatic collapse. It's more a gray, limp, floppy appearance. The child that rapidly just goes to sleep, who characteristically doesn't do that in everyday life. Fast breathing, wheezing. So any of those internal symptoms are obviously worrying. And for that, you need one thing, and that's adrenaline. It must be given rapidly. It must be given appropriately by an intramuscular injection into the thigh. And if a repeat injection is required, it goes into the opposite thigh. And that, thank goodness, will treat the vast majority of allergic reactions. And those reactions are exceptionally rare, but they occur. So we spend all our time, along with our multidisciplinary team, empowering families to identify, to avoid those foods, if the reactions, identify them, and then treat them using these plans.
And no, and George, I think that was excellent. I think one question I do have is because there's always this suggestion about when should you have an auto-injector? Are there any guidelines? Because again, we can't give specific advice, but I think a lot of parents ask me and saying, you know, my healthcare professional is refusing, but are there any guidelines that guides a healthcare professional to say who should be having an auto-injector and who should not?
Yeah, so most of the charity support groups, so Allergy UK is a very good resource for anyone listening who living in the UK, but many other countries have support groups, as well as the anaphylaxis campaign will endorse all nut allergic patients to carry devices. Most of the resuscitation guidelines would say certainly those patients at risk should be carrying adrenaline. And this is pretty uniform in most allergy societies throughout the world. That ideally, if you've had a diagnosis, particularly if you've got underlying asthma or you live remote from medical care, any of those risk factors, you should have adrenaline in your plan. I like to include adrenaline in the plan because it's very difficult to predict the severity of future.
Exactly.
So this is a benign intervention. It creates a lot of stress because you're carrying a device and it's always expiring and there's cost involved. So there's a lot of drama around the device. But you can only use it if you have it to hand. And if you don't use one properly, you will need two, or if you use one, you may need two. So I like, and this is supported by many organizations, for two to be carried by a nut allergic patient. And so some people will say, well, their last reaction was mild, why should they do this? Well, sadly, although fatalities are very rare, when you look at the analyses of fatalities, particularly in one US study, none of them had severe reactions previously. So I don't like patients to have to earn their adrenaline, to have to suffer before this gets issued. Yeah. We understand the condition and just support them.
Yeah, no, I think that's an extremely important point. Before we start going into who's at risk, I want to add, because I know our focus today is really on peanut allergy, but I want to just ask, because there were some questions that came through. If you were to have a peanut allergy, what is the risk of you having tree nut or, you know, other allergies like egg, for example, or milk?
So mono nut allergy or mono food allergy is now exceptionally rare, frustratingly. So the allergic journey, or the allergic march as we call it, will usually start with a young infant with eczema. Soon afterwards, if they're unlucky, they will go on to develop a food allergy, which is usually egg or milk. And that's pretty uniform throughout the world. In most countries, the commonest food allergies are egg and milk. Then again, in industrialized countries, usually where peanut is in the food chain, which is many places of the world now, including some of the developing world, peanut and one or two other allergens will come in as the next most dominant allergy. So your question is, if you have one allergy, will you have more? And the chance is far higher, yes. So the child that comes to see me and the mom says, you know, I fed my child scrambled egg and they're covered in hives and it's the second time I've done it and the kid hates egg. Although people spend a lot of time on the index reaction, and I appreciate that, I can tell them in 2 seconds the child is egg allergic. What's going through my mind is, what else is the child allergic to? do we still have an opportunity to intervene to prevent the other allergies? So the child who's egg allergic, again, in industrialized countries, stands about a 30% chance of becoming peanut allergic. The child who's peanut allergic stands a fairly high chance, depending on the studies, ranging between 25% or higher, of having a tree nut allergy. Remembering that peanut is a ground nut, a pea, a pulse, a legume, but they do share some proteins, and these allergies do run hand in hand. And of course, sesame, which is also a seed, like many of the nuts are, it's a seed of that plant. Sesame allergy is far higher. So these are allergies I always check for in the clinical history and testing.
And I think that for me, from a dietetic perspective, because as we work together, if I get a child, it makes it also easier with the new way of introducing solid foods, because we don't want to delay, if they're not allergic, to be really assured that I can actually go ahead and saying, go for that, you can actually do an early introduction. So that's really important for us as dietitians as well. So George, we're moving now into prevention, and I'm going to try to kind of summarize a lot of the questions. So the first question is, who's at risk of developing a peanut allergy?
So to put it in perspective, even in countries where peanut allergy is a significant problem, only 2% of the population, certainly in children, up to 2% are peanut allergic. So the vast majority of the population will not develop peanut allergy. But if you look for risk factors, the strongest risk factor is eczema. We now know that children become sensitized through the skin. So parents will come see me and they say, my child has terrible eczema. Which food is causing the eczema? What's going through my mind is which foods are landing on the eczema and a route of sensitization whilst your child is not eating that food. So we know from 25 or more animal models that if children eat the food early, regardless of what happens to their skin, and in the animal models, we found that you can block this route towards allergy. If the young child is not eating the food and it's in the environment and it's landing on their skin, they can rapidly become allergic. And in some animal models, after one application of peanut onto inflamed skin, whilst not eating the food, will start the journey towards developing antibodies. So eczema is a big risk factor, particularly generalized eczema in exposed areas, difficult to treat eczema. Eczema duration, when you see the infant, obviously duration's related to age, because we're talking months of life. But the longer your child has had the skin burning, this red, angry inflammation, the greater the chance that they'll have one or more food allergies. So that's the greatest risk factor. Family history increases it a little bit, but not as dramatically so as everyone is taught and everyone suspects. And this is such a new phenomena that there just aren't enough peanut allergic parents to account for all these peanut allergic children. There's something else driving this, and we know about environment. So eczema is a big risk factor, and then one or more food allergies. So if you're allergic to egg, we've just said that would be a risk factor for peanut allergy.
And I think that's an important, because we had about 2 questions coming through to say, you know, I've got a peanut allergy as a parent, and saying, does that mean it just transfers directly? And I think you've answered that there is a risk, but it's not, you know, not as high as what you think.
Correct. Yeah, the risk is not that specific. It's more a risk of atopy. So if mom has eczema, that's an equal risk as if mom just had peanut allergy or kiwi allergy.
Yeah. Yeah, so it's not as if it's a, you know, a 1 + 1 = 2, you know, so it's not as easy as that. Well, of course, I just want to say to those that are listening, we'll come back to the practicality with a parent and introducing peanuts. So if a parent has got a nut allergy and you want to introduce, because that's also an important question we need to go through. So, and I know this goes really down your expertise, can we prevent peanut allergy?
Yes. So based on our LEAP study that was supported by many agencies, done at King's College, Guy's and Thomas's, the NIH in America primary funder. So there were many people worked on this project. And the LEAP study was resounding success, that showing even in young children with egg allergy and or troublesome eczema, if you introduced peanut compared to not introducing peanut, that active group enjoyed an 81% relative reduction. So this is a very high protective effect through a simple intervention at around 7 months of age in most of these children, but from 4 to 11 in the study. And this is just through eating an otherwise healthy food. And it was an extremely safe intervention, extremely effective. So based on this finding, one government has changed its advice, and that is the United States. So if you have a baby in the US now, the guidelines are for the active introduction of peanut as part of the weaning diet, with some provisos within that we can chat about if you want. In the UK, we don't have national guidelines encouraging that, but we have guidelines encouraging weaning, which obviously peanut would be part of that from 6 months of age. And then within our British Society, the BSACI, British Society of Allergy and Clinical Immunology, and people can access that website and the early feeding recommendations. There is a recommendation from four months of age, to introduce particularly peanut and egg, where there's some evidence for prevention. And we now know in other countries that advice is filtered through to the population, like Australia, for example, where 9 of 10 babies now, this is wonderful data, 9 of 10 babies are now eating peanut during their first year of life. And that wasn't so a few years ago. So this study has affected an absolute about turn in the advice. We used to tell people to avoid peanut for prevention. We're now encouraging consumption, and it shows that this is a simple, accessible, affordable intervention, and that patients can actually do it. If people hear the message and they're properly supported, it's an intervention that can bring about an effect.
Yeah, and Georgia, just for everybody listening, you can get it. It's the parent. There's specifically PDF on parent prevention advice, and reiterate from the BSACI, the high risk is seen exactly the eczema patients, or if you've got another or egg allergy as following that advice. So we've really followed what LEAP, your criteria, has used for the early introduction. So at the moment, I think a question has come through whilst we're talking is, therefore, would you screen every patient that has got eczema for peanut?
Yeah, that's always a very difficult question to answer, because some 20% or more of infants in the UK and the US and Australia, for that matter, will develop eczema of some sort, a dry, itchy, crusty, oozy rash. And all those rashes are associated with some risk. Now, there's no way allergy services can screen all those patients. And so our message is that if you introduce peanut very early, particularly between 4 to 6 months of age, just before that milestone of sitting or around the milestone of an infant sitting, as opposed to the milestone of them walking at 12 months of age, if you get in very early, for most of those children, you can prevent peanut allergy. For each month after that milestone, you will lose efficacy as the child gets older and older. Yeah. And so the message is becoming more and more positive that as part of this very early weaning diet, as soon as it is safe to introduce this in the complementary solid feedings, and you'll talk to us as to how you can do this dietetically, as soon as it's safe for the infant to swallow these proteins, we like to get it in, particularly if there's some risk factors, and then screening becomes less important. Of course, if you have access to screening, it's very handy. If the test is negative, it gives you extra reassurance. If it's strongly positive, you will probably stop a reaction. If it's moderate or even more highly positive in the right setting, you will have a discussion with the family and say, we've only got 2 options: consumption, avoidance. Consumption may be associated with some risk if your tests are positive. Do you want to introduce that under supervision?
Yes, and I think that is also where the practicality for me as a dietitian comes, because of course we absolutely believe in that data. And if I may, I'm going to answer one of the questions, because somebody was saying, how do you actually practically achieve it? So I first want to say there were some wonderful dietitians working with you on the team, and there are some, if you read the papers for those healthcare professionals, there's some wonderful tips out there as well. But I have found at that 4 to 6 months window of opportunity, kind of window of period. So you have at that stage, first of all, you have it takes some time for you to develop, for baby develop lateral tongue movement. So you initially have just the forward and backward. So in a puree, it's the easiest. Now, we use a nut butter, and of course the nut butter that we would be aiming for is one that doesn't have sugar and salt in. Wherever you're dialing in from, everywhere in the world, you will have brands that won't have salt or sugar in, so I will trust your local dietitians to help. But I have found actually putting some really hot water just to thin it a little bit, to make it a thinner puree, and then either it goes like that or we mix it into baby porridge, into fruit. It actually is much easier than what people think. I think, Georgian, you can help me in that. One aspect that I really struggle with is that often I'm introducing it and yay, didn't react, and then they stop.
Correct.
And what is your message from that perspective?
Yeah, so people often ask for how long and how frequently and how much do you need to consume over time. So the LEAP study has prompted this intervention, and in the LEAP study, patients ate around a teaspoon, sort of heaped teaspoon, 3 times a week, and they did this for 5 years. Now, the good thing about the LEAP study is for those who weren't allergic, the families who were consuming, they ate that amount or more, and they were highly adherent, way over 90%.
Yeah.
And so when people say, well, what if you ate it for 1 or 3 years or once a week? You can't answer that question. You can't do a sub-analysis of this wonderful data. The EAT study, which was the uptake was lower with regards to peanut introduction and a little bit more sporadic and probably a little bit more real world when people are not that supported by a trial. When you do a modified analysis on the LEAP study, it would suggest that a teaspoon twice a week of peanut, at least a teaspoon twice a week. So like you said, Rosan, that's not very much peanut. This is a healthy food. People are obsessed with root vegetables and pureed fruit and rice as weaning foods. But there is no normal weaning food. You can get these proteins in, and Mary Feeney, an excellent dietitian, and others, and our group, have shown that the early introduction of peanut is safe. It doesn't leave your child overweight or underweight.
No, and I use it because it's a great source of protein as well. We bring in protein, it's got a little bit of iron in there as well. So I see it as part of a normal complementary diet. So it also reduces the need of giving meats and fish and things like that. It's a vegetarian, a great source. I think I agree with you. George, in terms of the interest of time, I want to move kind of more to the future. I want to touch on one aspect just before we move to oral immunotherapy, is just this: if a parent has got already a nut allergy, of course, I get these questions saying, I'm anaphylactic, so how do I actually do it? I'm of course I will support you, but is there any tips that you can give to say, okay, this is what you should do?
Correct. So firstly, severe reactions to nuts normally always occur through ingestion. Occasionally, it'll be through inhalation, possibly. It's very hard to find data scientifically to support that, or contact reaction. So if mom is peanut allergic and we're encouraging, and these are the most motivated of moms, we're encouraging the early introduction of peanut for prevention in the infant, we can find safe ways. And I've done this many, many times and not had a mom, touch wood, not had a mom react. So if mom just wears gloves, if she doesn't like the smell and has an aversion to the smell, which often develops over many years, you could wear a mask, which everyone's wearing masks these days, and it helps your kid get used to you wearing a mask. But you can introduce this safely, or you get another family member to do it. If you're only going to do this 2 or 3 times a week, hopefully you've got support around that to be able to introduce it. So even if one sibling is allergic, in most of the time, in willing families with due caution, you can introduce it into others.
Absolutely, and I concur with that. We always, as a dietitian, find a way. So it sometimes is on the days when the older sibling who's got a peanut allergy is out of the house and at nursery, we do it for the young one. Or we sometimes do it that it's the granny's day and granny introduces it if mom is the one that's allergic. The big thing is finding a routine that works. And as you say, the hand washing, and also I also talk about the surfaces at home, and the knife with peanut butter because it sticks everywhere, and just making sure those kind of basic things are taken care of. It sometimes is dad that does it because mom is allergic, or vice versa. So there's always ways of doing it. I'm going to move on in the interest of time to now a child has got the peanut allergy. Do you outgrow it?
So peanut allergy is very rarely outgrown. I can count on 1 or 2 hands the amount of patients I've seen that have outgrown it. Perhaps they just don't come back to you. If you look at studies, the numbers are around 10 to 15%. So it's biologically entirely possible to outgrow peanut allergy, but it's rare, which is strange because the exact opposite is true for egg and milk and wheat allergy. These are frequently outgrown. It's very rare to have a sustained allergy. So for most patients, it's very emotive. So you make this diagnosis and then you say this is probably lifelong, which is a huge blow. And very few families and kids will fall into that 15% to outgrow it.
Yeah, which brings us, we had at least 7 questions and some coming in as we're talking on oral immunotherapy. And first, in principle, does oral immunotherapy exist for peanut allergy?
So immunotherapy implies therapy on the immune system, and there are various modalities to do that. So for the vast majority of patients, families get by quite happily just avoiding peanut. You're very frustrated and cautious, impact on your quality of life, but the vast majority of peanut allergic patients do very well and are quite safe just with simple peanut avoidance and all the measures we mentioned earlier, carrying of a bespoke emergency plan and the knowledge around that. Our knowledge with regards to immunotherapy is very old, where you give small increments. And this was first described to egg many, many years ago, and more recently to other foods. And there are studies throughout the world really now looking at peanut, where small increments are given. So those studies are developing. And in fact, so obviously I have a conflict because we've been involved with all the therapies I'll talk about now, as an investigator, but that product is now licensed in the USA. So that's Palforzia, commercially available for children 4 to 17 years of age. That license does not exist within the European Union at the moment. Those applications will hopefully soon go in, and who knows, anyone's guess as to when that'll be approved, but hopefully in the next year or 2, that'll be a licensed European product. And so that's been trialed in many, around 500 in the one study, in the Palisade study. So if folk wish to read about that, the company name who's produced this product is called Aimune, A-I-M-M-U-N-E. There's a lot on the website. All their studies are free, open access in New England Journal of Medicine, and people can freely go and read about that. And there's a lot of knowledge around that.
So in terms of the practicality for parents, so because we had some questions saying, is it possible, we don't care about eating big amounts of peanut. It's all about, that if they're exposed, you can go to a restaurant and you kind of, if there are traces in there, you can at least be kind of calm about that. Is that an outcome of immunotherapy that you're saying, Rosan, that can absolutely be achieved, or are we still kind of a step away from that?
So this is not a cure. So we don't offer this as a cure, as in your peanut allergy your genes will silence and stop producing that antibody. It just, like you say, it just gives you that extra level of security that if you accidentally eat peanut in everyday life, you're very unlikely to have a reaction, because your maintenance dose is 300 milligrams, which is around a peanut's worth. And so that's what you set out to achieve. And you probably, or your child will likely have to do this for life. We've only been doing these studies for a few years, so we're not too sure what happens, if you stop therapy outright. We know that if you go from daily and you start interrupting that schedule, some of your tolerance may well fall off. And so, no, this is not a cure, increases threshold, but it is a therapy that's out there. Of course, there are other therapies being trialed, many others, of which the epicutaneous patch, and again, I'm involved in that trial, so I have a conflict. This is where you stick a patch containing peanut onto the skin every single day. And that's still earlier in its research and isn't licensed outside of the research setting. The company behind that, if people want to go and read up on that, is called DBV Technologies, a French company. And there's a lot on their website, and some of their early studies are also freely available for those who want to read on that.
And you answered already one of my last questions was, is there anything novel in terms of novel therapies? Because I know the patches are pretty novel in regards to, is there anything else that you feel? Because I think a lot of the parents say, okay, we're stuck with this. We're outside of oral immunotherapy. You've talked about the patches. Is there anything else that is out there that you think is promising?
Very exciting areas is the area of biologicals, these modern designer drugs that have been so effective in rheumatological conditions and gastrointestinal conditions, in the oncology world, and increasingly now have been researched in the food allergy world. Some of these drugs are already licensed and frequently used for asthma, things like omalizumab and many other biologicals. And I know a lot of families, like allergy families, seem to be particularly motivated. If they want to go and read about trials and want to know about access to trials, a very good resource is clinicaltrials.gov. it's a website where many trials are listed, and you can filter down to which country you're in, which condition, which age, and you can see if you know what research has been done in that area, and if those centers are still recruiting.
Yeah, and George, one of the questions we've had is in particular within the UK, are there centres that do oral immunotherapy at this stage and offer it to peanut allergic, or is still within the research domain mainly?
So it's entirely within the research domain. Cambridge has a product as well, a peanut incremental product that's been in formal research and now more loose commercial commercial setting. And some 200 patients, I believe, are on that program. And so that's the only commercial setting I'm aware of. So these products haven't come to the NHS yet. That's the next step. These programs require a lot of resource. You need to characterize your allergy at the beginning. So do a food challenge at the beginning so you know where your allergy is, what level it's at, possibly what severity. And then you go through these step-ups. You need constant communication with the center or the physician. And so these are not easy programs. And we're still crawling in our knowledge, but hopefully we'll soon be up walking.
So if you, I mean, we've had this last kind of question. If you have, we've spoken about peanut allergy. Is there any last parting kind of nugget of information or knowledge or motivation for the parents and the healthcare professionals that you want to impart, or you feel you've kind of shared everything now during this session?
Just to stress that it's a real journey, and parents, families, and kids, as they get older and more aware of the condition, will go through various stages. They'll find entering nursery very stressful, entering school, losing control of your child's diet and behavior as they get older and older, and eventually leave home. So this is a really stressful time for families. But with dietetic support, for those who needed psychology support, with good allergy support, you know, from nurses and doctors if you need it, that we can share that burden with you. The same concerns and queries that many families have is what we deal with. It's our bread and butter. We deal with this every day. So we can make that journey easier for you. But it is stressful. You will worry about this very rare event. Just to reassure families that the risk of a fatality or even a life-threatening reaction is exceptionally rare. These do occur. Fatalities are exceptionally rare. So you're living in fear of a rare event. And it's just about managing that. And also a reassuring word is that research has rapidly expanded in this field. We now have a commercial product available, albeit in the US. Hopefully soon this will spread to other countries. That is extremely exciting. You know, in my career, which is increasingly long, I haven't had access to any of this outside of the research setting. Also, we have a prevention strategy. So if this is applied just within the UK and US, we can be saving 100,000 babies a year from developing peanut allergy.
Wow.
Eating a simple, healthy, safe food. This is not a vaccine. It's not a drug. It's peanut. Just early consumption can protect many, many thousands of children from developing peanut allergy. That's exciting.
I think you can't end up a session with such it's an amazing message to have. Thank you, George. I want to just say I could see questions coming through, and it's not that we're ignoring you. It's those questions that came through just on eczema per se, very academic questions on why is eczema linked to peanut allergy specifically. There were questions on how do you test for intolerances. What I want to say is we are constantly running webinars. We also have webinars that are for free to have. There have been previous webinars on eczema, so please access those and check out. We'll make sure through social media that when these webinars come up, we'll look at those questions. I'm sure we could have been here for 3-4 hours, but unfortunately we are so grateful we had these 45 minutes from you, George, so really want to say thank you from my side. Nice. And also for those of you, if there's really a question, you can also email me if you really feel but I want to reinforce that the question will be answered in a very general way. Thank you very much. I'm going to stop recording now.